It is my pleasure to introduce you to Dr. Mark Gonzalgo. Dr. Gonzalgo is a very good friend and colleague of mine. We are partners in kidney cancer. He has incredible skills as a surgeon, as he will show you with some of the types of surgeries he does and examples. And what is important to emphasize here is that with the team that we have with urology, medical oncology, pathology, the ones who do kidney cancer are really specialized in kidney cancer. And that is one of the take-home messages for you and also to spread the word, okay, that patients who have advanced kidney cancer or localized kidney cancer should be treated by experts, by people who have experience in kidney cancer, because that is in the patient's best interest. So, Dr. Gonzalgo.
Dr. Marchand, as I set this up quickly here, I just wanted to thank Dr. Marchand again for the kind invitation to be here, as well as Mr. Nicholson and the Foundation for the opportunity to present this morning. I think Dr. Sharma gave a wonderful overview of kidney cancer and some of the information that's needed in order to understand what's involved with the treatment. And I couldn't have said it any better than myself, and I appreciate that, really setting up this talk as we focus on the surgical management of renal cell carcinoma, because I represent kind of that one specific area in the paradigm of treatment. And you'll see, I think the important theme, especially for patients with advanced disease, is to really understand that this may take multiple avenues of attack in order to successfully fight the disease and cure it. So we'll focus right now for the next 20 minutes or so on the surgical part. As Dr. Sharma set up earlier in her talk, it's important to understand the stage of disease. And from a surgical standpoint, we know that we break it down into three basic techniques of open, traditional surgery, laparoscopic surgery, or robotic surgery, and I'll go into the nuances of that, because I think in this era, as Mr. Nicholson said, that we're trying to provide the latest advanced treatments, and from a surgical standpoint, many of the tumors that we treat are with a minimally invasive approach. It may not be applicable to all tumors, but that certainly can be used to help patients, and it certainly has some advantages, and I'll go over that in the next few minutes. But it's important to understand that depending on the stage of the tumor, a surgeon may need to use one specific treatment over the other. And as I've highlighted on the left side here, and I think it shows up here with the arrow, that certain types of tumors may be amenable to what's called a partial nephrectomy, where we're actually able to save some of the kidney instead of having to take the whole kidney. But again, every situation for every patient is unique, it's different, but it's important to understand that there are certain factors that influence the decision of what type of surgery a particular patient will undergo. And as I mentioned, we really evolved from an open era to a laparoscopic approach, and then to many cases now doing a robotic approach. I'm going to show some pictures and videos, so if you are able to see them, that's fine. If not, then you can I guess turn away. But this kind of represents, in one instance, a picture of a common approach that, as an open surgeon, we can use. Just for orientation, you can see the patient's head is to the left of the screen. And this is, again, represents one avenue. You can see we approach certain tumors through the flank. And this actually was taken, I was on a medical mission, actually, to the Philippines, and a person had a kidney tumor, and we're approaching it from the side in order to treat that patient. And again, this has been done for many years, probably longer than we've been doing laparoscopic or robotic surgery. But in this particular situation, this was the best approach for this patient. And you can see, typically, this is associated with an incision. And in some cases, for certain patients, it can be even bigger depending on the extent and stage of that type of tumor. I wanted to move forward to kind of case presentations. We do this typically in medicine, and even as patients or family members, it can be helpful to understand kind of background on patients. In this case, this was a young man who started having abdominal pain. He went to the emergency room. Again, something wasn't quite right. Oftentimes, presenting symptoms can include hematuria or blood in the urine. And as for this particular patient, a CT scan was obtained in a very large tumor on the left side. It's not easily seen on this, but I'll circle that for you. And sometimes when the tumors get quite large or things can go on in the kidney, it can be associated with bleeding. Thankfully, in most situations, that bleeding will not go throughout the entire abdomen because the kidney is encapsulated in a very good but thin sheet of tissue that will contain that blood. But for this patient with this type of large tumor, from a surgical standpoint, it would be perfectly acceptable to do this via an open approach, but it would require a large incision. This was circa 2005, and I pulled this out of the archives. That's me doing a laparoscopic approach for this tumor. And you can see from the setup, when someone from a surgical standpoint mentions the word laparoscopy, you're talking about viewing things typically on a television screen like you would be watching at home in 2 dimensions. Typical laparoscopic instruments look like this, and as you saw from the previous picture, you're at the bedside of the patient handling these instruments in order to get the tumor out. And so this is a little grainy because it's actually quite old video, but you can see working the laparoscopic instruments that are really straight and trying to uncover the kidney. And you'll see here, this is the kidney that's really contained within what we call a Gerota's fascia, and it's bled. So behind this, literally a sac that's containing the kidney, and what's underneath it, including the blood, is going to be removed. And so one important part from a surgery standpoint is the controlling the blood supply to the kidney, and that's done here. We have a variety of instruments to do that. And so when someone thinks about taking a kidney out, it's not just something as simple as opening up the skin and removing the kidney, because it's surrounded by many vital structures. So this is just one example of that. And this is actually what it looks like afterwards, and in some, so you can see a lot of blood and the tumor was in there. So in the early 2000s, that was a laparoscopic case. The evolution of robotic surgery began. There are a number of advantages to robotic surgery, at least from a surgical standpoint. Some of them are listed here. We've got a lot of different types of instruments that we can utilize, but I think the biggest thing is as you'll see here, is the 3 dimensions that we can view the surgery. It's in high definition, and again, using the wristed instruments, we can get much better options in terms of dealing with different types of tumors. So this case here is a patient that has a left-sided tumor. In this case, we try to have options to save the kidneys. We have access into the abdomen with very small instruments. And this is one part when people say, oh, I'm using the robot to do the surgery. It's not as if we press a button and the robot does the actual surgery and we walk away, right? It's still the surgeon that's doing the robot, but I hope that this provides you with an understanding of how that's done and how, again, like many things, we operate and function as a team in the operating room. And so, oftentimes I'll have patients say or ask me, Dr. Gonzalgo, you're going to be doing the surgery? And I say, yes, I'm going to be doing the surgery, but I'm not going to be doing it alone, because you have to understand that there's a team of nurses, scrub techs, anesthesiologists. So just like we deal or try to treat cancers, in the clinic, in the operating room, it requires many times a very highly complex team. So in this situation, this was a young gentleman with a 10-centimeter mass. He had blood in his urine, and again went to the ER because of this, and then found a tumor in his kidney that was quite large, 10 centimeters. For this patient, it was not spread to anywhere outside of the kidney, and in this scan you can see it's on the left side again, this mass or conglomeration, and here's another view of this tumor looking as if you were facing the patient, primarily involving the lower half of the kidney, but in this case also central portion. So we decided that the best avenue for this patient was going to be a radical nephrectomy on the left side. And you can see here, comparing it to the other videos, and it's sped up a little bit, so that's why it's going fast. a pretty efficient surgeon, but not this fast unless it's sped up. So, and again, working with the blood supply, as Dr. Sharma mentioned in the first talk, that the kidneys are very vital organs. In fact, they receive about 25% of the blood supply every minute. So in order to take the kidneys out, or in certainly a partial nephrectomy situation, trying to preserve the kidney, it can be somewhat even more complex. And again, we have a variety of devices that allow us to do this safely. If you look at certain guidelines, and these are AUA guidelines, since I'm a urologist, the American Urologic Association, in this case for T1 renal masses, I've circled a lot of the types of surgeries that we do for this, what quote, smaller types of tumors are what we call nephron sparing surgery, or trying to save kidney function so that it potentially does not put patients at risk long term for kidney disease or renal failure. And I've circled here that in many of the guidelines, even depending on the type of patient, that partial nephrectomy is recommended. But one of the questions is what defines really a small renal mass. Some people would argue you could even do partial nephrectomies for T1B tumors, or for select patients in T2A tumors when the cancers can be quite large. You've heard the saying, I think, in real estate that in many instances, location is extremely important. And so just like in that situation for tumors, the tumor location, not only the size, but the tumor location is important to make that decision on whether or not you can save a kidney and do a partial nephrectomy. This is one of the earliest studies that highlighted the importance. This was done actually when I was at MSK by one of my colleagues, looking at chronic kidney disease. Because remember, if you remove one kidney on a patient, you're left with the other one, and you really have to take care of that, right? A lot of patients will say, what do I need to do afterwards? Well, one of the very important things you can't overlook is taking care of your blood pressure and making sure that's monitored. In many cases, patients are going to go and if they haven't already, see a nephrologist because you really have to take care of that solitary kidney so that patients fear, of course, the possibility of dialysis in the future. And that, again, is one reason why, if possible, we try to do a partial nephrectomy. And that's shown here, and these curves show that basically if patients had a partial nephrectomy, they did better long-term than patients who had a complete nephrectomy in terms of developing what is defined as chronic renal insufficiency. So in this case, for example, I had a very young woman, 36 years old. Again, similar situation, pain, you go to the emergency room. She had a scan, and unfortunately for her, this was a smaller tumor, 3 centimeters in size, and at 36, she's otherwise very healthy, and you can see that tumor here on the right side as measured there. And so from a location standpoint, from a size standpoint, that this tumor was very amenable to a partial nephrectomy. Again, as I said earlier, you don't just go in there and take the tumor out or take the kidney out. There are a lot of structures. As I mentioned, partial nephrectomy is a little more complex than a radical nephrectomy, since you have to temporarily stop the blood supply to the kidney in order to cut out the tumor. And so after isolating all the blood supply to the kidney, and we're clamping it here, temporarily clamping some of the arteries and the veins that go to the kidney, we go and then work on the tumor. So again, many steps are involved in order to do this very efficiently and safely for the patient. Again, this can be done laparoscopically, but the instrumentation might not be as good as the robot, and this certainly can be done via an open approach. So there's nothing wrong with doing that in terms of a cancer operation, but from a recovery standpoint, the minimally invasive approach is certainly, I think, that patients appreciate. And so you can see the tumor there, making sure that we get it all out in terms of a base. And then after the tumor is cut out, obviously we have to take care of this kidney, because if we were to release the clamps, it would simply bleed. And so this is done with suturing. I'll show that here. One of the things you have to realize too, we see it on the big screen. I'm in the operating room seeing it, but it's magnified 10 times. So any little amount of blood that we see, sometimes we interpret or over-interpret to be a lot of bleeding, when in reality, this is not more than a few, literally tablespoonfuls for the patient. And so again, you can see here, we put the kidney back together, we use clips, we use suture material, and I think one of the most rewarding parts as a physician and a surgeon is that this patient is going to go home literally the day after surgery. And then she should do well. Pathology is clear. And again, for this size of tumor, hopefully will not need more treatment. But I'll talk about that in the next few minutes. And again, to stress the importance of what we really value here at Sylvester and University of Miami and working in a multidisciplinary team. So this is another patient. This time it's a 57-year-old gentleman, similar size, but again, this is a much more challenging location because this tumor is literally almost smack dab in the middle of the kidney, so it's not on the edge, and that can be seen here. In some instances, the patient may have been offered a radical nephrectomy in order to remove it, but after I've isolated the tumor, it's literally there and plucked out, but you can see a cavity there in the kidney. And again, with this size of tumor, hopefully the patient will not need any further treatment, and he goes home the next day. We mentioned earlier, I think, patients, when I operate on surgery, and they go home and I see them in clinic, and I put Dr. Mershon's picture here because, not specifically because of this particular medication, but to stress really the importance. Someone asked, I think Dr. Sharma and Dr. Mershon here, when patients see us either in clinic before surgery or after surgery, again, it's an individualized assessment. It's an individualized decision. In fact, this morning, I was talking with Dr. Mershon about a patient who I saw just yesterday in the clinic. I don't know if he's here. He's supposed to come today. And, the question was, this gentleman had a 7-centimeter tumor, it was outside of the kidney. And so do we take the kidney out first as a first step, or does he go, as they had mentioned earlier, to see Dr. Mershon and Dr. Sharma for evaluation and systemic treatment first, with the consideration for surgery afterwards. So again, we are now in an era where we're able to provide patients with these types of therapies, either most commonly in what's called the adjuvant setting, so that's right after surgery, and this is for one particular agent. There's also a number of clinical trials. This particular clinical trial, I'm sure you've heard about Jaime. Dr. Nahar in our group is trying to get this on board here at the University of Miami. And you can see it's for patients with a wide variety of stages. But the unique thing about this is that instead of just taking that patient and having them go to surgery to remove it, which certainly could be one arm, it's one arm of the study, and that's standard of care. Now you're taking that patient and you're treating them with nivolumab, which is one of the newer agents. Then you're doing the surgery, and then you're treating them again afterwards with a medication, and all in the hopes to effectively cure this disease in a much better way, hopefully, than what we are doing now. Again, that's the effort that we try to put forth with developing new research protocols or being involved in clinical trials. But I want to emphasize again that all of this would not be possible by working in a vacuum and just seeing any single provider for the care. So in closing, I think I like showing this slide because we talk about, well, what has been done historically in the past. And I had that phone. That was one of my favorite phones, the Motorola Razor back then in the day. But, that doesn't even exist now. And I think they're trying to rematerialize it. But things are different, right? I mean, and everyone is well-informed. Yes, we're thankful to surgeons and also, obviously, our other colleagues for treating the cancer. This is a surgical talk, so the patient comes back and they're thank you for removing my cancer, but they're wondering about other things because again, a lot of patients are still highly functional. They're very informed, right? YouTube is out there. They'll watch the video. And in fact, I have many patients say, I've seen your videos on YouTube, and they want to get back to work. That's very important, and back to fully functional status. And I think that's one of the other things too that I've seen as an active participant and bystander, since I'm not a medical oncologist, I'm a surgeon, is that and Dr. Mershon, I'm sure, is going to address some of this in his talk, is that the treatments these days are are much better on the patients than they used to be. In the interferon days, when patients had to be, when you got your treatment, you had to be in the intensive care unit, and you couldn't leave the hospital. And sometimes, thankfully, you can go get the treatments and go home. In some cases, the treatments are pills outside of the operating room. So I think my take-home message is, again, from a surgical standpoint, is that, we do robotic surgery. I do robotic surgery. It may not be applicable for every patient, but certainly is an option, with cancer control being the number one priority, regardless of the approach that's used. You need to select the appropriate patient to do the open, laparoscopic, or robotic approach. Not all tumors are created equal, and I'll put, not all surgeons are created equal either. It's a fact, because you can have differing opinions on how you would treat one tumor depending on who you speak with. And then lastly, I think this is the most important take-home message from my time with you this morning, is that some patients will require multimodal treatment. Again, as emphasized, they're going to need to see not only a surgeon, but a medical oncologist. And then again, this, I think, us being here in the symposium highlights the importance of us needing to continue with our research efforts, clinical trials, and then getting patients really involved. That's why I'll put a plug in for Mr. Nicholson, fill out the forms at the end, so that we can understand what is needed, not only for treatment, but after treatment and beyond. Okay, so thank you very much for your time and recognition.